ready. I think we start.
I think we'll start. So people can join as they do. So welcome
Sure.
everyone to today's learning and sharing session. And we're going to go through a panel on oligometastatic breast cancer. And we chose this topic because we thought it's truly multidisciplinary, and that's what our sessions so far have been about. So we know that metastatic breast cancer has a really wide range of presentations, and oligometastatic disease is distinct, where the tumor has spread to limited sites beyond the primary. And the teaching is that it has not acquired enough mutations to make it widely metastatic yet. But a uniform definition is lacking, and all our local ablative therapy trials are older, included all the subtypes. Now we know how important subtype is to making decisions about chemo, radiation, and surgery. And a lot of the discussion we are going to go through today will be in a relatively data-free zone. So I'll start with a multiple choice for my panelists, and welcome to all of them. We'll start with Manjula. Manjula, for you, what is the best definition of oligometastatic disease? Is it A, B, C, or D, as shown on the slide? Is Manjula there?
Yes, ma'am. I'm online. I'm just looking at the definition.
Great. Yes.
Can I say none of them?
Okay. So what would your definition be?
So while there are many studies that say, they focus on the number of sites, I would say low volume disease or low burden of disease, which can be addressed by ablative therapies, maybe in patients who are biologically suitable.
I think that's a great definition, and I think it's clinically practical and what we all do in the clinic. Bhavna, if you had to choose one of these four, which one would you go for?
So I would go for 1 to 5 C actually of metastatic disease, irrespective of number of organs affected. So we've had that is most optimal.
I think that's the closest, because like Manjula pointed, this is a very limited definition.
Yeah.
So if we look at the ESMO statement, and as Manjula correctly referred to, it is low volume metastatic disease that is highly sensitive to systemic therapy, and you can get a complete remission and a long survival. And you want to use a multimodal approach for these patients with a curative intent and very selective patient population. And we do need a good prospective clinical trial. And these are some definitions that we do throw up by ESMO, STRO, and ISTRO, where, of course, it's less than or equal to 5, all tumor locations safely treatable. So you have the genuine de novo, which is, for example, the breast primary with a solitary bone met, genuine de novo disease. Then you have metachronous disease. That is, the patient is in remission, but then comes up with 1 or 2 metastases, something like oligorecurrence after a treatment-free interval. We also the definition where we treated a polymetastatic disease and we've induced an oligometastatic disease. And sometimes during active treatment, the patient develops oligoprogression. And we may have strategies if they've responded for a considerable length of time to kind of just change one of the elements or radiate that spot and then continue with the same treatment. And we'll discuss all of these options. So there is some data to say that maybe 3 lesions is a better cutoff, but it's still up in the air. And we frequently refer to HR positive or HER2 positive disease as oligometastatic and treat with curative intent rather than TNBC. So is Dr. Bhakri around? Because I need my nuclear medicine specialist now. Is he there? No, then I just suggest that one of us takes this up. Bhima, would you be okay to fill in?
Yeah, Ajinkya is here.
Okay.
He's there?
Yeah.
Then why is he not answering? I
He's
Ajinkya,
responded on the chat box.
Ari, you can't get in, is it?
No, I'm not able to unmute.
Oh my goodness. Princey, will you have a look at this technicality, please? So let's start with we know that staging, I mean, if you strictly follow guidelines, which in private practice becomes a little difficult. Manjula, for stage 1, 2, and 3, what is your approach to staging these patients? I mean, what do
As a
you do in
routine,
practice?
I get a PET CT done.
For
So
stage
even
one
if it,
also?
Sorry?
For stage one as well?
Yes, yes. I get PET CTs done. And I have seen a patient, HER2 positive disease, 0.5 centimeter tumor with florid axillary mets. Uh, uh, and we need to get a PET CT done as well. We've also seen a patient with a 2 centimeter tumor and a single liver met, HER2 positive disease.
I've seen that. I've seen that as well. So let's ask Neeta, although she's not on the panel. Neeta, you've moved now from
Yeah.
Yes, I was just going to
wanting
say
to
that.
know.
Yeah. I
So,
knew I was going to come.
after giving us lectures and lectures how
Yeah,
not to do PET CT, what are you doing now?
So I'm going to be very honest and hand on my
Huh.
heart, I give patients the option. What I explain to a stage 1 patient is that your risk of knowing distant disease is less, of having distant disease is somewhere to the tune of 1 to 2%. The choice is yours to make. I'm happy to do an ultrasound and X-ray because my concern is related to, liver is something that we are more concerned about and we think is higher with her too, etc. But if you're very concerned, then you need to get the PET done. And I will be honest, most patients opt to get the PET done.
Yeah.
I am
I
yet
think
to see a patient who says, "No, I don't want it."
But Neeta,
I'm
maybe in private practice, isn't it?
Yeah, but so the thing is, I don't force them to do it. I tell them that you have a 1 to 2% chance of having additional disease.
she's playing very safe now.
But I do. I'm telling you, I
I'm
actually have
telling
this
you,
conversation
Neema,
with them. I draw out algorithms and give it to them. But
most
if you're
surgeons in
asking
private
me,
will do it.
but if you're asking me, would I not even offer it to somebody? I'm not going to do that anymore. And I'm going to be very honest. In TMH, we never really gave anyone a choice,
Yeah, that's
right?
true.
Yeah.
Okay. So
It was
what we
more of
do
a
is
dialogue.
a stage 1 patient, we just tell them, go get a mammo, go get a core, blah, 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 get on with your life. We'll plan surgery. 2 and 3, we tell them, go and get investigations done. So there'll be a very small fraction of patients that one actually has that conversation with. So it's about dialogue. So it's very fair that most of us in private will be on a slightly more defensive approach, where you get everything done and say, please get everything done and stare at it. Because I've had enough people come back to us when we were in TMH as the second opinion, because some surgeon trying to be Puritan wouldn't get the scan done. That person goes and sees a medonc. I mean, I know that both of them are going to growl at me, but every medonc will get it done. Right?
Oh, no.
And then, the patient has had bone disease picked up, and then they come back and fight with that surgeon. So I've had to actually write down like a letter from TMH saying that even we would not have recommended it, blah, blah, blah.
We've had shocking instances where a stage 1 TNBC has come back, has had a PET.
Yes.
Okay. Has had
And come back with disease.
and then come back with healed bone mets.
Yes.
It's been a nightmare dealing with these, but then the PET would not have picked it up. So, you're still in a bit of a dilemma.
So I'm going to say that, especially oligo related, and Reema can tell you this out of the database that she has. Often enough, we see patients who after chemo come back with more sclerotic sites.
Yes.
Yeah.
Which were obviously lesions which we didn't pick up earlier.
Correct. So
and
that
this would be at least 5% of all the oligos that we see. So not really less.
Yeah. So so you look at it as that's your upfront group where you may not have picked that up if you didn't
picked it up.
Yes.
Yes.
And Neeta, it's also to do with bone scans. So
oh my God. So I think Ajinkya, if he's here, should talk about it also.
Yeah.
But
So,
I think
Ajinkya, what is the preferred? I mean, we've all discussed PET-CT, but if you had to choose the optimal staging for a patient, say with a stage 3 clinical stage 2 or 3 breast cancer, and you wanted to do, what would you do? A CT with bone scan, MRIs, or a PET-CT?
Definitely a PET CT, because PET along with the PET we definitely have a whole body CT. So if lytic lesions are there, that may be missed on a bone scan, because which mainly picks up the blastic metastasis sites. So definitely a PET scan is recommended. And more of this lobular carcinomas, which may present with small primary tumor, may present with florid mets.
Absolutely. Yeah,
So,
yeah.
so
Okay.
that will be
But
definitely picked on a PET. And
Also,
okay,
sometimes marrow disease.
yeah, it will be also definitely picked on a PET. That will
okay.
not be seen on a bone scan or anything.
What are the chances of staging if you were to compare CT bone scan with PET-CT? These two modalities
Generally,
were compared. You say PET-CT
generally,
is the treatment, I mean, the investigation of choice. So is there any data to show it's superior?
definitely, a PET is generally advised in a locally advanced breast cancer, because in that stage, PET may help in detection of some supraclav nodes or at distant sites, which may be missed on a CT or something.
Mhm.
Basically, PET CT, as compared to CT, helps in detection of marrow lesions, and where the anatomic criteria are not met with generally of nodes which are morphology like less than a centimeter size, which may be picked on a PET CT.
Okay, why am I not able to move my slides? 1 minute. Yes. So this is the PET ABC trial where they actually sat and compared PET versus CT bone scan for 2B to 3 patients. And they found that a larger number who had PET done were upstaged to a stage 4. Most of them had change in treatment. And half of those who were upstaged on PET were oligometastatic with a single lesion. So definitely it's a better modality. I won't say it's perfect, but it's definitely better than a CT bone scan. So, do functional scans add anything more? And would they, and in what kind of tumors would you use a FAPI or a FES scan? And would they give you a more accurate picture?
Presently, FAPI is mostly used in this cancers which don't show FDG uptake, like the basically mainly in gastrointestinal tumors. Uh, uh,
Yes. Would it help
like
in
signet
lobular?
Yeah, there are some studies, but not yet in the recommendation to regularly go with the use of PAPI in lobular carcinomas.
Right.
At present, mainly in initial staging with signet ring cells or other types of gastrointestinal cancers, which may not show uptake with FDG PET. And
Okay.
there is no as such now current recommendation with respect to treatment response also with respect to FAPI PET.
Okay. All
So
right.
they are done
I
in complementary with FDG PET.
and I think FES scans are also becoming available. And this is
Yeah.
just a patient who was supposed to have curative disease. And these were the innumerable bony sites that were picked up with a functional scan in an ER positive patient. So I think this is coming in a big way, and it will complicate things for us even further. So now we come to the surgical aspects for OM, and we have a lot of older data, surgery for pulmonary meds, for liver meds, and these were very old data. The systemic treatments were not optimal. There's retrospective metastatectomy, which for liver, which led to long OS but high complications rate. And now I come to the favorite topic of my surgeons. So, in a patient with oligometastatic disease, what about surgery for the primary? Is it helpful? Is it recommended? And what does the data show? Manjula, we'll start with you, then we'll go to Neil.
So I think the first thing to do is to decide whether the patient falls under the category of oligometastatic disease.
So you prove
Is
that.
this
You prove that.
then
That has
keeping
been
that
proved.
in mind, if we go by the data of the last 5, 6 years or so, patients wherein the primary has been operated and ablation to the distant metastatic site, they do show improved progression-free survival and they do better oncologically. However, now we know that that is very controversial with the results of the NRGB 002 trial. So yes,
Absolutely.
but
We
there
will
are,
be
but
coming
there
to
are,
that. Neeta, what's your take?
So, the way one looks at oligo is that you don't have any really truly randomized data. A lot of it is, the SEER database or the NCBD audits, which tell you that as long as there was, single lesions, bone only, all of them did well, and you could consider surgery, and of course, there's better local control. The Turkish trial did
before Turkish, let's talk about your trial, the TMH trial.
So the TMH trial had
25% oligomet.
No, it had 7 patients with oligomet only.
This is what is given in the data.
No, that's not oligo.
But
It's 1 to 3.
Neeta, you use the 3
1 to 3
criteria.
No. So the 1 to 3 or greater than 3 was not single site, single organ. Right? So it could have been 1 bone, 1 brain, 1 liver.
So you didn't use the broader definition of 5. You used 3 for these things.
Exactly. Right? So for us, truly oligo, there were only 7 patients on this study.
So this is the data that you guys had.
Correct. So in that study, we showed that, with disseminated disease, patients who've responded to systemic therapy and then were randomized to surgery or observation, the surgery arm had better local control, which is expected, but the distant disease seemed to progress faster in patients who had surgery, which comes similar to Folkman's data for angiogenesis, that the growth factors hone in now onto the metastatic site, and that potentially is why they are increasing. Our data is very similar to the ECOG-ACRIN study by Seema Khan, very similar to the Japanese trial that's come out now, was published, I think, 2 months ago, and very similar to, what's his name? Who am I missing? There's a third study, which for some reason I've totally missed. But
and they all show the same thing.
Similar results. Okay.
But Dr. Shona,
but Neeta, some systematic reviews do show benefit.
Yeah. So that's what I'm saying.
So we are going to discuss it during our cases because we are talking about that patient select. So surgery front for the primary in an oligometastatic setting.
So the other thing
the way to go.
But so the other thing that you must notice, Shona, is that all 3 studies, the Indian, the American, the Japanese, as well as the
gave systemic
trial, gave systemic first.
Yes.
Right?
To
the
see the
Turkish
response.
Study, and the Turkish study is the only one where they randomized patients at the outset. To local regional therapy versus not. That study truly did have a few oligometastatic because 70% of their disease is bone only. 30% of their disease is single site only.
Yes, and that's why it was a positive trial, probably. The biology was different.
Potentially, different biology, better low, like Manjula said, low burden disease.
Right.
But Dr. Shona, so even though this evidence is very conflicting, there are papers that have, when they collate the data, they say that patient selection is very important, like we discussed. So by that, they mean patients with single site Mets, bone only Mets, hormone receptor positive disease, those who have good performance indices. These are the patients who perform even oncologically better.
Yes. So you have to go by that. And one of the drawbacks that is repeatedly described with our Tata study is that only less than 10% got anti-HER2 treatment for the HER2 positive. So there are, and older systemic therapies were used. So things are rapidly changing. And we come to the next part. What is the data for radiotherapy ablation? So Rima, explain SBRT in 2 sentences, the rationale for it, and what is meant by a biological effective dose.
So basically, SBRT is nothing but high dose radiation therapy, which is focused in such a way that the surrounding normal tissues, critical organs that surround the target volume, receive as low a dose as you would otherwise want. And it delivers using something called as VMAT, which is type of IMRT, intensity modulated radiotherapy. So the margins are kept very tight, and very, very high doses are given such that everything within the target volume basically has to die. So that's like the most colloquial definition I can come up with of SBRT. And the rationale is that you would want all the active metastatic cells to not contribute to further dissemination. So sites that are usually not operated can undergo radiation therapy. So that is what the rationale is for that oligometastasis, for using it in oligometastatic disease. And BED is basically biologically equivalent doses. So basically what we see is most of these studies of SBRT have shown that if you give a sort of low dose and call it SBRT, it really does not work. So you have to give it enough dose. Usually we say 100 gray biologically equivalent doses to the target volume for it to work, for it to cause ablation. So wherever possible, a very high dose in fewer settings really helps. And coming to what is the data, so we have a whole lot of retrospective studies. We have a lot of phase 1, phase 2 studies. And the only phase 2 randomized study that we had was NRG BR002, which was negative. Unfortunately, it has still not come out with its full paper. It just came out with a bang in one of the conferences, and it was negative on all its endpoints, which was quite disheartening.
It was very disheartening because everybody was excited after Comet, and but doing, I think, a dedicated trial for a particular site is very important. I think that's a lesson you learn from this. But
pulls us closer.
Any reasons for you thinking that this could was negative? Was there any problem with the design? Was there any problem with the way the patients were randomized?
So really, there were a couple of drawbacks. The only thing is that a lot of patients were metachronous oligometastasis, not upfront or synchronous oligometastasis in this setting.
Okay.
We did have though a larger number of patients with ER positive and bone only disease, which otherwise we would have thought things work for. But that didn't happen. We don't know what kind of doses were used for them, what volumes were used, how was the treatment given. So all of it is in a black box. Yes. And a lot of people hypothesize that those are important things for one to consider before calling a trial negative or positive.
Very important. And I think when they calculated the median progression-free survival expected in the design, they maybe miscalculated or underestimated the benefit of the observation arm. And it was actually better than the experiment arm. So it was something that was a problem.
That might have been still okay. One can deal with that fact if your experimental arm still did better. But unfortunately, your experimental arm did exactly the same as your standard arm. That was the problem.
Exactly. That was the problem.
Now, one other thing that I can point out is that in the standard of care arm, we did not know what kind of systemic therapy was given.
Can you just mute yourself, whoever is talking? Excuse me. Who is this? No, please continue.
So what I basically wanted to say is that in the standard of care arm, we don't know what kind of systemic therapy was used. So if long-term systemic therapy like CDK4/6 inhibitors and those type of systemic therapy was used, Whereas in the curative setting, if you stop the systemic therapy at your standard AC Packley or something like that, and then don't follow it up with maintenance therapies like you otherwise would have in a metastatic setting, will make
make
a
a
big
difference.
difference.
Yes, absolutely. So that could be one reason as well. So, Neeta, do you want to questions? There are a lot of questions in the chat box.
Yeah, so I
So,
think some of them are me only because these are situations I've been coming across. So, see, Rima, just to go continue with SBRT, I'm going to ask. So, I have a patient with an oligomet in the lung, right? It was a deep lesion. We clipped it or supposedly clipped it before we started chemo. Post chemo, you cannot see the lesion, you cannot see the clip.
good God.
So,
This
we
is
discussed.
classically how it happens in TMH also sometimes, no, Neeta?
Exactly. So now the thing is, we have discussed the options, which is I cannot to offer surgery. It's just going to be a random wedge because we can't even palpate anything. We can't see a thing. We don't expect to be able to even palpate anything, and it'll be open surgery, which is really pointless for a situation like this. One option we've given her is close observation. I have taken it up with the MDT saying that is SBRT an option where they overlap the original images and try something?
So
Dr.
usually we don't
Neeta,
do that. We don't
sorry,
do
sorry,
that.
sorry to interrupt, but Dr.
Yeah.
Neeta, I've spoken to the thoracic surgeon because I had a similar case,
Yeah.
and they said that they don't need a fiducial placed in the lung lesion prior. They compared the pre-CT, the
Yeah,
pre-chemo
no,
CT
I've
and the post,
checked
and
this
they're
with
able to.
four thoracic surgeons, all of whom said don't touch it
Yeah,
surgically.
even I would think that some of these patients don't actually need it. A
Yeah.
small subset of
Agree.
patients who are extremely chemo
Absolutely.
or targeted therapy sensitive,
Hmm.
they will never come back at that site.
Yeah.
So,
So
you know,
close
the thing
observation
is,
is
it
best.
won't come back at that site, but that breast will probably progress at some point. This is,
No,
I've
so
faced
we
this
are
At which I will
situation.
operating the
operate.
breast. No, so
Yeah.
At
I'm
which I will
operating the
operate.
breast. The
But don't,
question
if
is
you
on what
can't
to do
see it,
about the lung.
but if you can't see it, why are you radiating? What are
Yeah,
you
we won't.
radiating?
We
So
won't.
that, yeah,
You're
so
going to continue your systemic, right?
that's the option we've given her is, sort of just stay on maintenance therapy.
Must
And
be
if
HER2
when
positive, no?
it is.
Nita,
So
one thing I
transport will do
will
the job.
Yeah.
the one thing I will sort of tell you. So while
Hmm.
it might look very beautiful when I'm comparing or superimposing the
Images.
PET CT on my current planning CT where
Hmm.
the patient's taken a very nice breath hold or whatever,
Ah,
when I'm actually matching on my CBCT, my cone beam CT images are not that great.
okay.
So something that I cannot see on my beautiful CT, I will definitely never be able to match accurately on my cone beam CT.
Okay.
So you have to see something for me to contour that and deposit those. Now radiation doesn't deposit in thin air. It has to
Yeah.
have something to deposit those into.
Yeah.
I mean, while Manjula may say that some thoracic surgeon will go ahead and remove that wedge, that is possible. But radiating thin air is not possible. So if your
So
radiologist tells,
unfortunately, this is a very deep lesion in
hmm,
the original scan. So even the thoracic surgeons have put their hands up in the air saying no.
right, right. So, and I was just coming to a point. So if your radiation oncologist tells you that they can go ahead and treat it, it's time to change your radiation oncologist.
Fair enough.
What if this was ER positive, HER2 positive? I mean, this is the patient that I had. Single lung lesion responded beautifully to NACT with targeted therapy. Breast, not so much. I mean, probably intermediate response. Would you still consider, I mean, surgery for the primary and
Yes.
ablation of the Met?
So ablation of the Met again is the same answer that if you can see it, you ablate it. Um, and the surgery for the primary, yes, as long as it didn't progress, I think we would go ahead.
Yeah, I agree. We would do the same at TMH as well.
Yeah. I think that's a fair approach.
So the second question I have is actually more for the medoncs because this is something we're seeing very often now with TDXD, with Pembro, with every new thing that has come up into the system. There are a whole bunch of these disseminated disease, but not something that is, all over the place, but outside of the realms of what we traditionally called oligo. which we have not treated the primary site, saying it's not oligometastatic. We put them on palliative systemic. They stay under control for 2-3 years. The mets disappear. Okay, but that
I've got
primary.
some cases like
Exactly. So
we
because
can
now
talk
see
about
what's
that.
happening is these are all coming back.
We can talk
And
about
yeah, so
these.
we need those addressed. And my third
Yes.
and only other question, which is something that I have fought repeatedly at TMH, which I think Rima is fed up of me, is if you have a patient with a solitary brain met,
No.
are we using the same principles of oligo versus is this biology and prognosis just different and we need to call it palliative?
No, so
So,
we would treat the brain metastasis also with radical intent. Why would you label it as palliative suddenly? So if a
so
patient presents to us with, say, locally advanced breast cancer or OBC, whatever you want to call it, and a single or a solitary brain metastasis, more so we will still go ahead and treat it. If surgically removed, then surgically removed followed by radiation or upfront SRS if the lesion is very small.
Is
In
this a synchronous met that you're talking about?
yes,
Yes, she's
yes.
talking about synchronous.
So the only exception for OMD is really leptomeningeal disease in the
Yes,
CNS.
Okay.
or
We
a
don't
very
think,
large lesion for that matter.
yeah.
So I've been very skeptical about brain only
Yeah.
because I find that it just tells you that the biology is a little different. So I haven't been able to sign up completely on that concept yet.
But I think our anti-HER2s and our
Maybe, maybe now
ER
with the way things are
positives,
changing so much. Yeah,
yeah, they do have
probably.
some penetration. Yeah.
Fair enough.
Okay.
Okay.
So this is the first case, a 55-year-old lady, homemaker with no comorbidity, postmenopausal, has a T2N1 disease clinically. The core biopsy shows her to be triple positive with a high T67. There is a metabolic lesion retroareolar, right breast, with small satellite lesion just inferior to it, with a large axillary node on the same side. And she also has a small hypodense lesion in the caudate lobe of the liver, very close to the IVC, which is most likely metastatic. And mild activity in the sacrum, query, or likely metastatic. So does she fit, Bhavna, into your definition of OMBC?
I think yes. I would also like to do an MRI of the sacrum just to see whether there are multiple lesions there.
Fair enough. And intent of treatment, therefore, would be curative?
Curative, yes.
And if you gave her, if you treated with curative intent, you would do local therapy or systemic therapy first?
Systemic first, yes.
I think all my panelists are on board with that. And I think that's a very reasonable approach. So we really don't know where OM belongs, whether we should have another stage for it. And we all know early, locally advanced, metastatic, and here we've got oligometastatic somewhere in between. Our treatments are well documented for each subtype across the spectrum. And we need to take a call whether to go the early way or to go the metastatic way when we get a oligo patient.
Shona,
So
I'm
she
going
goes
to
to,
ask one question, and this is actually to both Bhavna and you. Is there any circumstance in which you would do surgery first or locoregional therapy first in an oligometastatic patient, or would it always be systemic first?
so if I had an elderly lady who was strongly ER positive with a small primary and a single or two bone mets, I would be very happy sending her for surgery first.
So I think the disease is systemic. The scenario Shona described is very rare.
It's rare, very rare.
And if a patient is elderly and you think is not fit for chemotherapy or systemic therapy, then but I mean I've treated one patient with just letrozole and pH as well, and had a fantastic response, and then done a
No,
local
HER2
regional therapy.
positive, no, not really. With HER2 positive systemic, always. So
Or
Always first, yeah.
TNBCs.
And TNBC as well, yeah.
TNBC, I'm reluctant even to treat oligometastatic with curative intent because I really don't know how they are going to behave.
So they do
It's,
they do worse.
yeah. And
We've analyzed our data for nodal oligometastasis, and TNBCs come way below
way below.
the average oligometastatic patient. So they are the worst of the lot. HER2's only a little better. Triple positive,
Yes,
better, good prognosis. So, and ER the best.
Yeah, the best. Is Dr. Gore there? I bet Gore. No, I don't think he's joined. Okay. So she
Yeah, ma'am,
goes on to
I'm here.
you're here. So
Yes.
what's your take on this?
So HER2 positive, madam, we do treat. Yeah, the TNBC, I agree with you that I don't think we should be looking at an oligometastatic in a TNBC because the HER2 systemic therapy is really works very well for these group of patients. ER positive patients probably being on a CDK4/6 initially systemic therapy, if later on they do respond very well, then maybe local
You can
therapy for
consider
that one
surgery.
can consider surgery for that. But for
Yeah.
TNBCs, I would not. Even in the era of immunotherapy, I would still not go if the patient
No,
is eligible
absolutely.
for that. I would still not
Absolutely.
go in for that.
So I would slightly
I-
disagree there because, TNBC, now you have so many options. And if a patient is truly oligometastatic and you've given systemic therapy for 6 months or 8 months, I would go for loco-regional therapy, which is what we do. And I don't know,
So
we have.
for example, okay, let's put up a case. She's 28, she's BRCA positive, she's triple negative. Okay, she has a single met in the lung and she has a stage 3 primary. So she gets her she gets her chemotherapy. If you're treating her in the curative setting, then you do a surgery for that.
Yeah, give her
That's a
capecitabine or olaparib. Give her olaparib first, and then followed by capecitabine, and then has a good disease-free interval for a year. We would actually address the lung met.
But
Yeah,
do
but
we
I
usually
don't.
treat patients like that?
Yeah,
But
I have so many. I've currently got a 29-year-old who's we
with
treated
oligomet.
with oligomet. We ablated the sacral, similar situation, sacral met, and she's doing fine, and she's still on olaparib.
Okay. Because I
And we
rarely
have a
get
patient with
oligomet.
Manjula, I think, on Apollo Proton we treated. I'm still following her up. And a
The
big
one with the
decision about
mediastinal
doing
node?
the one that also, and another one with, SBRT to the liver. And I don't know, I think we gave Proton, I can't remember what. But it was so many patients like that. Of course, you can say it's anecdotal, but I think the biology is good. They've had a fantastic response for 6 to 8 months,
Yeah.
and some of
Okay.
these patients have a complete response. The disease just disappears. So I feel there is no harm in doing something which is quite, finished over
Especially in a
5 days
younger patient.
in a
Yes, of
young
course.
patient.
Yeah.
And I agree with you. They have a very poor prognosis, and I think in about 80%, 70% things will progress.
So
But Dr.
Yeah, but
while I
I
think
Bhavna,
don't.
they
how
have
would
poor
you?
prognosis, I sort of also agree with Dr. Bhavna here that you will find uh, a few of them as long-term survivors.
Yeah,
So
Yes.
But
one
Correct.
cannot,
Dr.
as
Bhavna,
of now, judge.
yeah,
triple
Yeah,
negative breast cancers are very aggressive and they're going to respond to chemotherapy anyhow.
yes.
So how do we separate the good biology
No,
TNBCs
not
from the
everybody
worst
responds,
biology?
Manjula. There are 20% of my patients who progress very badly.
On
Like I
treatment.
currently have, we are taking her for surgery because she's progressed through AC, she's progressed through Paclitaxel carbo, but it's early stage. So, we are taking I mean, she's going to do badly. If she had an oligomet, I would never even consider addressing that. Or if they have a not
So,
RCB score of 3 to 5, something like that.
So if
so
you have two
let's
patients,
just say,
TNBC, one with a Ki67 of 90% and has responded
No, Key
beautifully through the
67 is
mediastinal,
useless, actually. Yeah. So
you
I would
won't go by
no,
that.
it's not a good marker. No, it's not a
Okay.
good
not a
marker.
good marker.
Also, I
And
would like to say that responders or non-responders, so non-responders, whether it is TNBC or any other molecular subtype, non-responders don't do well.
Yeah.
So patients who are progressing while on systemic therapy, even if it is just ER positive patient, these type of patients don't do well at the end.
I'll tell you the data. For TNBC, a PAT-CR means much more than a PAT-CR in a HER2 positive. Because 15% of PAT-CRs in HER2 positive will still relapse at some point.
Yes.
Whereas in TNBC, it is not that common, not that common. I'm not saying it's not possible.
But it's
But
not
I
that common.
rarely see, I rarely see a PAT-CR coming back with disease.
Yeah, I agree.
Anyway, go on. So she receives her chemo, dose 10 ACTHB, 8 cycles with clinical monitoring. PET-CT is done. And if you look at the primary and the axillary node virtually disappeared, and so also the caudate lobe met. So what type, and the sacral met as well. So what type of surgery to recommend, an MRM or BCS, Manjula?
I would consider breast conservation surgery if I'm able to. I think there were two lesions to begin with. You mentioned one retroareolar and satellite nodule.
Yes.
And I would have clipped both of them prior to chemo.
Right.
And if I know that I will be able to address it at one go when it disappears, and I would do a breast conservation surgery if feasible, followed by radiation.
Fair enough. So she undergoes a lumpectomy, ALND, and she has a complete pathological response. Rima, role of radiotherapy here in the adjuvant setting, metastatic sites, and Bhavna, what about maintenance?
So coming to adjuvant radiotherapy, if we have taken or chosen curative intent for her to begin with, then I would go ahead with adjuvant radiation. She will undergo radiation to the breast and the supraclav, plus minus the axilla, depending upon what kind of disease she had at baseline and how much was removed. And boost as usual. And regarding the metastatic site, again, liver, if I can't see, I can't treat. So I won't treat. If patient wants to undergo RFA, it was clipped and wants to undergo RFA at that site, they can go ahead with that. But radiation is not going to be possible. So sacral lesion, even though it is not PET avid, can sometimes still show as sclerotic lesion. And it is anybody's guess what happens to these. So there is again no data to tell with modern systemic therapy, how many of these can continue to remain CR forever. The older data showed that only 3% of patients are long-term survivors after good response on chemotherapy. But this proportion may have increased or swollen with the systemic therapy that we today see. So that is what I would do. I would go ahead and treat it, unless it was too small and tiny, where I think that the PAT-CR would also correspond to the bone site.
Okay, let's talk to Advait. Advait, what would you maintain her on? She'd had dose 10 AC, she's had THP.
So in this current scenario, our maintenance therapy, which looks at dual anti-HER2, I would continue this lady on a dual anti-HER2 maintenance. There is currently no data to de-escalate to only trastuzumab if we have reached this situation. So this patient, I would continue with a dual anti-HER2. We do have quite a lot of patients in clinical practice also who have not just oligometastatic disease, but even florid mets who tend to go into a CR using dual anti-HER2. Almost 50% of them land up in that situation, and we are continuing the dual anti-HER2 for them.
Any situation where you continue with single agent TRAST besides financial constraints?
In a situation where the patient is not tolerating pertuzumab, because pertuzumab is not as easy as trastuzumab, we do see patients getting a lot of diarrhea because of pertuzumab, which can become a real bothersome symptom. Patients can get at times, especially when we are using the intravenous preparation of pertuzumab, the diarrhea was much more as compared to the subcute one, which is currently there. So in these two subgroups, I may de-escalate looking at the quality of life of the patient, and then go on to continue the trastuzumab as a single agent.
And would you consider adding CDK4/6? Because we have some evidence from the Patina study that patients
Yes.
who were maintained on fast PERT and CDK4/6 AI had a OS benefit.
So
But
I
we
haven't
treated her in
used
the
it in
curative
practice,
setting.
madam. Yeah, I
Oh,
haven't had the experience using it, but
right.
we've used the Monarch HER2 regimen for a select group of patients where we've
Yes.
used single agent trastuzumab with abemaciclib and AI. And these group of patients also tend to do well with the combination.
Very
The
well.
addition of
Yes. Yes.
abema to pertuzumab, again there is an additional toxicity of the GI side effects which both these
Idea.
drugs produce. So that is something we should keep it in mind. So in that scenario, I would use the single agent trastuzumab with abema and an AI because that generally tends to
Absolutely.
be well tolerated.
So, Shona, there's a question
Okay.
actually in the chat box, which says that
Right.
would you continue hormone therapy lifelong or till progression, or would you give it for the 5, 7, 10 years as we do in adjuvant?
Good. So I think her progression will tell really what you need to do. But if I've treated her all along in the curative setting, I'm not going to change tracks now and continue lifelong. I don't want to give her that additional toxicity. So I will complete transport till a year, and I will continue the hormones for about 7 to 8 years as extended adjuvant. That's what
But
I would do.
she was
Bhavna,
an ER
what would you do?
positive.
I agree with you.
He
I
was
would stop at 7
triple
years,
positive.
and plus
Yeah.
having a PAT CR here in ER positive, HER2 positive is unusual, so it's great result. I would give subcut Traspar and then give oral letrozole only. I probably would avoid CDK4/6 inhibitor here. I mean, she's had a fantastic response.
Yeah. Yeah. She's had a great response, and why bother with more toxicity? I
Yeah,
agree.
yeah.
So patient selection is very, very important, as we have discussed. And let's jump to the second case. This is a younger premenopausal lady with no significant family history. She has a 5 centimeter lump in the upper outer quadrant with adrenodes palpable. The core biopsy shows a HER2 enriched tumor, which is grade 3. The FNA of the adrenode is positive. She also complains of lower back pain. Staging scans are done. We've got 3 lesions in the liver now, suspicious for metastasis. Indeterminate sclerotic lesion in we wanted to be absolutely sure before proceeding. So we've done a biopsy from the liver lesion and it confirms disease. Now, when you get 3 lesions in the liver, how many of my colleagues would recommend an MRI to look for more lesions?
Yes, MRI.
Do
Yeah,
Yes,
you
we
would
would
do
do an
that?
MRI.
yeah, and
Yes.
spine as well, the whole spine.
Yeah.
So she had an MRI and there were actually 3 lesions. But like I said, I had a patient recently with 2 lesions in the liver, did an MRI, there were 20 lesions.
Yeah.
So she jumped from being oligometastatic to polymetastatic. So I think that's an important take home. Be very careful when you're treating them with curative intent and labeling them oligometastatic.
And a
So what's the next?
GADO MRI would actually detect more liver mets rather than a PET CT because
Yes,
generally the
Yeah.
PET CT is a very low resolution one.
Definitely
yes,
for liver and brain metastasis, MRI is the best.
is the best. Okay, so
And the size of
that's
And
each
for
met is also important. Even if it's
yes,
limited number of mets, the size is
correct.
important.
I
Yes, so
just
these were
wanted to
all
add one thing. So for low resource
G.
setting, even targeted USG in a skilled hand can tell you that the
Ah,
number is just 3 or more. So that is also possible.
Yeah, and a contrast enhanced USG also at times we ask our radiologist to get it done when we have a issue then.
Yeah.
Bhavna, do you agree that you would start treating her with Paspert and a taxane?
Yeah, I would start her on systemic therapy, but I would also check because she's presented with back pain. How bad is the back pain? Whether we need to give her palliative radiotherapy there. The
Okay.
intensity of the pain, how bad it is.
Okay. So her pain is not too bad. She's controlled on very weak opioids and then goes off. So She does very well on PHP. As you can see, these liver mets virtually disappear. And there's a significant reduction in breast mass, and the L2 lesion is stable, so it was probably non-metastatic. Would you refer her for surgery at this stage after her 6 cycles, or would you continue with systemic treatment? Advait, you want to come in?
So surgery for the local breast lesion, yes, one can consider that, because if it's a lesion which was 5 centimeters before and she's responded so very well, I would look at a surgical referral for the local treatment. In terms of the liver, I would probably not do anything for the liver. I would continue with the systemic therapy. And of course, there are options
Bhavna,
for.
what would you?
So
Yeah,
I would,
yeah.
I would refer her for breast surgery, but we must be mindful of the data that, the patients who with metastatic disease who were operated, they actually did worse for those who had HER2 positive disease. But here, then I would address the liver as well, along with the breast. So I would address both, because if you're going to treat with curative intent, yeah, I would address them together.
Because if we're
Either as
comfortable
ERT or
leaving the
surgery.
liver lesion behind, even though it's disappeared, then why do we want to touch the breast?
So she doesn't get operated, Ushona, and she
So
does
we
well.
didn't. She does
Yeah.
well, because see, we have not given her TCHP. We were very clear that she's metastatic to start with.
Yeah.
And we kind of we didn't want to label her as oligo because she had 3 lesions 2 centimeters big. And we were not comfortable. So we continued HP. And this is an actual patient, and she's done very well for 4 years. Then the scans are done, obviously, every 4 months, then every 6 months. And then she gets a little FTG activity in her most latest scan in the same spot over here, but no other site of disease. Now, at this stage, Bhavna, would you switch her systemic therapy, or would you refer her for surgery?
So she has oligoprogression. So I would
Correct.
address it locally with local treatment.
So any of my panelists want to defer, or anybody with an opinion or comment at this stage?
So my concern with this type of disease is that technically, if you follow the principles of disseminated disease, that the minute we get the primary out, the Mets may be the next target and start growing.
But that Anita, that's like so theoretical.
So my thing would be that if you have additional targets still to offer, I would be happy to consider surgery. If you don't have targets, which is often what happens to us, see, you're saying you'll send this patient to us at the first site of progression. We've often seen patients by the second or third progression, which means that they've used up the TCHP, they've used up the TDXD, they've used up something else.
Poor thing has not used up anything, and she's had 4 years.
So
I would, Shona, continue the same systemic therapy after surgery.
So I'm coming to that.
Yeah.
So she's referred for breast surgery. Okay. And Manjula, what here is the importance of the margins? So you'd make sure you got everything out, right? And would you offer recon if you did an MRI?
Yeah.
Yes, yes, we would offer her. I mean, it's a cosmetic decision, something that if she's keen on it,
She's
yes,
young.
100%.
She's 30. Yeah.
Yes, young or old, if they're keen, we offer reconstruction.
Yeah. So now
Even
she
if
has
she's
residual
60, she
disease,
should
which is
Shona
what
get.
we know, which is what we know, okay? Because that's what was picked up on the PET scan. The margins are clear. She's still HER2 positive. Would you continue HP or switch treatment at it? She's had 4 good years. She's got a tiny local recurrence, which continues to be HER2 positive. It's 1 centimeter. You've been able to get it all out. What are you tempted? Would you follow Catherine here, because this is not fitting in Catherine, or would you just continue the same thing?
Yeah.
Ma'am, was the recurrence also involving the cutaneous area? Because the cutaneous recurrences behave a bit different than the actual breast parenchyma.
No.
Okay, then in that situation, I would probably continue with the same systemic therapy rather than changing. If there was cutaneous, then generally they tend to behave more aggressively,
Yes.
especially in the HER2 subgroup, and that's what we've seen in practice, and that's where we would change. And we burnt our fingers in such situations
Yeah.
before.
But like I said, there's no data addressing this. It makes sense to continue the same thing and reserve your other anti-HER2s for later when you have some, I don't know, this is the way I think, where you have a larger burden of recurrence. And she's proved herself to be of a good biology, even though she's ER/PR negative. So, Rima, would you do PMRT in this case if it
No,
was
no,
no, because
it will be
we
an
got a
overkill.
small
Yeah.
yeah.
I would be okay with
Absolutely.
a wide excision in such a patient.
But it's a 5 centimeter tumor to begin with
Yes.
axillary nodes that were positive. So if I were to operate, then we would have to give PMRT as well, isn't it?
No, no, we are not following the strict pathway that one follows as per NCCN guideline. We are
So the
teetering
basic thing
between
is
two subgroups. So I would not strictly choose just one and go ahead after 4 years to give PMRT. I mean, why would you think that PMRT will help in this case where for 4 years there's been no activity, nothing has grown,
But
she
the
has
question of
responded.
PMRT is to prevent local recurrence, isn't it? I mean, otherwise, like what I'm thinking is when you're giving targeted therapy, she's been doing very well for 4 years, and then suddenly there's a lesion in the breast, which is why we're addressing it. So then we have to give complete local regional therapy. Otherwise, we might as well just change the systemic therapy and not address the breast.
No,
But
for a
she's had
1 centimeter
MRM.
tumor.
But she's had MRM. If she had
Correct,
BCS, I would give RT. But
correct.
not.
So in a patient with a 5 centimeter tumor, node positive, if we were to consider her
4 years.
curative and she was
Yeah.
not oligomet, we do an MRM, we give her radiation.
No, but this is 1 centimeter.
1 centimeter residual CA. To begin with, I think it
It's
was
not
5.
residual, it is
But that was
it
4
is
years
Oh,
induced
ago.
sorry,
oligorecurrence.
oligoprogression.
Yeah.
Oligoprogression
So
or
that was 4 years
recurrence.
ago. 5 centimeter was 4
So
years ago.
basically, are you going to treat the tumor's stage that was there 4 years ago, or are you going to
Today.
treat the tumor as it is now?
Now.
So I will again look at disease-free interval. So suppose the disease-free interval was say 6 months, then I would go ahead by and there is no real cutoff. Now, if you will, someone in the panel can suddenly ask, what if it is 9 months? What if it is 10 months? I don't have an answer. It's just clinically, if it appears as though it's an indolent disease, something that has responded for a considerable amount of time, then I'm happy to treat just the local disease that has come up again, rather than and this is a classic example. So all oncology sensibilities would say that you should treat the 1 centimeter rather than the 5 centimeter that was there 4 years ago.
What if now the residual carcinoma is 1 centimeter, but what if she was node positive, say one node positive? Would you still not
Yes,
No,
so
you
if
give
it
her
would.
was node
PMRT?
positive, Manjula, I
You
agree.
would
If it
give.
was node positive for one node positive for a post-mastectomy setting, we are treating all
Yes.
patients right now also.
Yes. Yes.
Especially if she
Yes.
was an
Yes.
oligomet like this, I would have treated.
So, Rima, here's my question. What if you do, the patient ends up having a breast conserving surgery?
Yes, I would go
100%.
ahead and treat her like I would treat any breast conserving surgery.
Okay.
I will go ahead and
So
treat
the
the breast.
principle that you're saying is that you would treat what the current disease is.
Yes.
And if it is something that needs PMRT because of the current state, you would give it. If it's something that was breast conserving surgery, you would give radiation. So it's not that you wouldn't, but you'd follow the principles for the current disease.
Yes, and this is what
Okay.
we do for all recurrences also, Neeta.
Okay.
Say suppose this was irradiated also. Let's believe that she was irradiated to begin with, and this is how she's presented now. So suppose this is a small tumor that has come back. It is not involving the skin. It's still in the parenchyma within the tumor bed or whatever. And you've done a mastectomy for it, I will not treat it. So if she is a T2 disease, I will not treat it. But if she becomes T3 or T4 and it follows in our post mastectomy radiation protocol, then we will consider, because it was a locally advanced recurrence. We will treat it now again. So we will consider for re-irradiation. So similar principle. I'm not saying the same thing, but similar.
Fair. There's a question in the chat that if when you have the oligo recurrence, would you be happy to instead do a lumpectomy first, look at targeted therapy and response, and then offer formal surgery, or would we just go ahead with formal surgery? Manjula.
I didn't understand. Lumpectomy
So
first
meaning that you
means
just
wide
wide
local
excise.
excision.
Yeah, so you wide excise that area that's progressing, give systemic, see response, and then consider, or are we okay to go ahead? And I think what the panelists more or less answered is that we'd go ahead with formal surgery directly.
Formal
You may
surgery.
not address the axilla.
Yeah.
No, I mean, if you're going ahead with surgery, you might as well do. Do the complete thing. Address the axilla as well. Otherwise, we don't touch the breast, and we just change the systemic therapy and see how how the breast lesion responds.
That's such an overkill for a 1 centimeter lesion.
Continuation of systemic therapy or addressing the axilla?
Changing the systemic therapy.
Systemic therapy.
Because, you go to a drug like TDM1, a great response, so badly tolerated.
So,
and
my
honestly,
only point here is,
I think Transport is.
My only point here is, we are trying to negate, axillary staging in patients with very small disease, very good biology. And here we're looking at oligometastatic disease, oligorecurrence or progression, where we're like, we'll just do the lumpectomy and not address the axilla. It just
I have
doesn't
a
feel
question
good.
to my surgeons. Would my surgeons do a sentinel node in this patient? You do a wide local excision or a breast lumpectomy and a sentinel node. You evaluate the axilla, you're not able to find anything, PET is not showing anything, you do a good ultrasound. Would you give a trial of sentinel node?
We could. It may come node negative, but again, this is oligometastatic disease. And if we look at conventional definition, it's stage 4. And sentinel node biopsy is not something that we do in stage 4 disease. And I think I think the gentleman in the chat, what he asked, even that makes sense, because when we are discussing not giving PMRT and we're just going to address the oligo progression or the oligo recurrence, then we might as well, we can, and give changing the systemic therapies and overkill. Then we attempt a lumpectomy, leave the axilla, continue with systemic and see how she responds, because that's what we're doing. We're testing behavior.
So I will just sort of piece things together here. Most of the oligometastatic trials say that the local disease will be treated as per local stage. So say suppose the anecdotal patients that all of you have seen for stage 1 with say one site of oligometastatic disease, I would be happy to treat the stage 1 as stage 1 breast and the oligometastatic site as the oligometastatic site. I will not do comprehensive regional nodal irradiation for this lady and treat everything that is treatable. So that is not how the principle follows. So one has to stick to a sort of SOP or a guideline or some set rules when you're treating these patients. So I have had patients where we've not treated supraclap because this patient was node negative to begin with. Anecdotal, of course, in oligometastatic setting, but that can happen. So we've treated only breast also. So I think the principle is the same here. Difficult to digest because this does not fall into how we traditionally treat patients.
Like I said, there's no data. There's absolutely no data what to do here. But I don't think you can de-escalate everything. So I don't know, in my understanding, you do an MRM, in which case you would get the axilla cleared. Or if you did a sentinel node, then would you give some radiotherapy? I don't know.
Or else we do a lumpectomy and we radiate the breast and the axilla. It just feels
It's all
incomplete
upon
because
radiation oncologist, basically.
because we're so used to, I think, following a protocol, and this is what we do. So when this is a bit, it's a different scenario, it just feels very unorthodox. That's all. So I think it's we need to start thinking out of the box.
I think that's why we're discussing it.
One thing I would want to
We need
bring
to start thinking.
to anyone's notice over here is that these patients can also develop second primaries. So after 4 years, this could just be a second primary. We don't know that yet. So
We don't know that.
keep your minds open for that as well. So patient can present with that. Suppose this patient would have presented with one bone metastasis. Would I have treated all her bones? I would not have. So it's similar, something similar.
I'm
So
going to
typically,
say
if this
that,
patient has presented after
it's-
4 years, we would rebiopsy the lesion.
Of course we would.
yeah, but Manjula, just to take off on the same thing, I am not so averse to doing a sentinel node if
Mm,
there's no uptake anywhere else, and that's the only site,
mm,
because
mm.
I feel like we're adding more morbidity to what may not be necessary.
So she
Yeah, like an
actually,
overkill.
I'll tell you what actually happened. She was biopsied before. It confirmed a HER2 positive disease. Okay. Then she undergoes, she opted for an MRM. We did a sentinel node at that time. That was negative. And then she received the MRT. So this is what actually happened. She continued HP and she's well 1.5 years later on it.
Do you give drug-free holidays
So,
to such patients?
wait, do you give drug-free holidays?
Uh, so not for these patients because HER2 positive disease without therapy is going to progress very rapidly. I think these are the group of patients where if there is just a local recurrence in the breast, it's just a tip of the iceberg which is waiting to crash down on someone. And in this scenario, even de-escalation is something which we don't think of. Unless the patient gets some toxicity because of which we have to modify our treatments. But
Exactly.
I would
Exactly.
not really give a drug-free holiday for this patient. In fact, I have a patient who's on trastuzumab and she has been on trastuzumab lapatinib for last 9.5 years and she has liver metastasis. I'm trying to tell her that since about 6 years that okay, let's try and just go on to single agent because she's getting a lot of paranoia, but she refuses to give up lapatinib.
He refuses. And we've all got patients like this on Traspert for 7, 8 years, and I really don't
Yes,
know what to do with them. But I'll tell you what I do, which is out of the box. I give it once a month.
yes,
After six
yes.
or 7 years, they are
Yeah,
like,
yeah,
man, we don't want to come to the hospital every three
yes.
weeks. Or I arrange the subcut at home and they take it in.
Yeah.
And so the way it goes.
I think
So
once
I
in four
have,
weeks is a reasonable option,
yeah,
madam.
yeah,
That most
yeah.
of the patients generally get tired coming every 3 weeks to the
Yes,
hospital for their
yes.
doses, but once in four
And I
weeks,
get
generally they don't
tired of
mind.
seeing them also. Yeah, yeah. So we go to our last case, and this is a 59-year-old postmenopausal lady with controlled hypertension and a good performance status. He was diagnosed previously 4 years ago with a stage 2 ER/PR positive, HER2 negative grade 2 tumor, 2.7 centimeters in size, node negative, was given 4 TC in the adjuvant setting, radiotherapy, and put on AIs and zoledronate. She presents now with a 3-month history of a dull right hip pain, and the X-ray shows a lucency in the right femur head. Staging PET shows 3 lesions: right femur head, right acetabulum, and right anterior rib. So, do you agree that we need to perform a biopsy? It's been 4 years since the first presentation.
Yes.
So would all my so we do a biopsy and it still continues to show a strong ER/PR and a HER2 fish, HER2 2+ fish non-amplified. Would you necessarily radiate the right hip? There is a low risk of fracture. That's what the orthopedician says, but there is pain.
But she
So,
has pain.
Bhavna, would you send her for local RT? She
Yes,
asked me.
I would. I mean, I'll just see how much the level of pain is, but I would send her for local RT and start as you have done. Exactly that. No chemo.
So what's the data? There's a lot of data coming up that CDK4/6 is safe during radiotherapy. So when do you generally start CDK4/6 in your metastatic patients?
For those who have
Before
started,
RT or after RT?
so I haven't found a difference in toxicities for the radiation dose which is used for palliation. So if you're using 30 gray 10 fractions or 20 gray 5 fractions, we haven't have seen a lot of bone marrow suppression because of that. Having said that, if it's a large area, especially the lumbar spine or the pelvic
Yes,
radiation, that's an area where
pelvis.
I would hold that's where I would hold the CDK4/6 and see how the counts are behaving about 2 weeks post completion of radiation, and then decide whether to start off with the CDK4/6 or just go ahead with the AI or fulvestrant or the other drugs which are available now.
Absolutely. Bhavna, what do you do in practice?
So I never start CDK4/6 with radiation because, I mean, all of us have had patients who crash their counts within 2 weeks of when they come for the 2 week check. Their platelets are 70, 60. So now you'd never be able to figure out it's radiotherapy or. So I usually wait for the radiotherapy to finish, repeat the bloods about 7 to 10 days later, probably 10 to 14
Yeah,
days
and then
actually, and then start.
I don't have the paper with me right now, but there's a very provocative paper saying that giving CDK4/6 during radiation gives you some immune effect and
Improves.
improves the effect of the Rima, there is a paper like that, no?
Yes.
They said that
Yes.
about immunotherapy as well.
As
And then,
well.
there is like this way or that way. It's all,
Yeah,
I think, theoretical.
No, but
I
I
think
think it's
they
better to be safe.
Safe.
And my radiation oncologist just finish off the marrow somehow. They're really expert at finishing it off. I mean, I'm like holding my head in my hand sometimes. So I'm very careful with pelvic.
But I
Uh,
agree with Dr. Advait here.
so the
So
patient starts on systemic,
I'm, I was just,
wait 2 weeks and
yeah,
then consider.
yeah, yeah. On larger portals.
So the patient gets, yes. So we repeat the PET CT after 4 months of systemic therapy. And she's responded in all 3 sites. And for 3 years, 36 months, she's on fulvestrant CDK4/6. Then the PET CT shows a single liver lesion and no other disease. Advait, what would you like to do next?
single liver lesion, she's done well for 3 years on fulvestrant CDK4/6. This is a very tempting situation to look at ablation for the liver lesion also, where a microwave ablation can be looked
Yeah,
at, or even an SBRT, because we've seen that continuing CDK4/6 beyond progression also works in about 40% of patients. What are the options we have following fulvestrant and a CDK4/6 inhibitor? So one thing I would do is do a biopsy of that liver lesion, get an NGS here because we don't have much options post fulvestrant CDK4/6. We know that there are the newer SERDs which are there, but currently out of reach of most of the patients in our
not
country,
available.
unless there is a trial.
Correct.
Or we have to go with a very, very difficult combination of everolimus with exemestane or chemotherapy. So in this scenario, if a performance status is good, I would look at a local microwave ablation or an SBRT and continue with the same systemic therapy.
So the patient is thinking exactly the way you are. She's feeling very well. She doesn't want to change it. We know that the options are inferior. You can, possibly change to the other treatments you mentioned, but there are 4 to 6, barely 4 months or 5 month PFS benefit. So she goes for, I think, SBRT and continues with the same treatment. And after 15 months, so she gets a great benefit for 15 months and progresses with multiple lesions. So, Bhavna, do you think that we did her good by continuing the same treatment?
Yes, I think, for 1.5 years almost, she did quite well and continued on endocrine treatment, That's I think really important. I think
So, what's your experience? I think for continuing CDK4/6 beyond progression? Do you use it in your practice?
So I think you had oligoprogression, you addressed the oligoprogression and continued on the same treatment actually. So if a patient has progressed on CDK4/6 inhibitor, I tend not to actually. And this trial actually again showed what you were talking about with the earlier study, that SBRT probably does not add benefit in metastatic breast cancer. But again,
So
these
hold
are
on,
such,
this was one study. Yeah.
Hmm.
So I looked for another study. There is
Avatar,
an
yes.
Avatar study described from Australia. And
Yes.
Yes.
Which showed,
1/3 of the curve trial was TNBC. Here,
yes,
100% were ER positive, like our patient.
and they
That
benefited.
was a positive study.
Yeah,
And
yeah.
what you wanted to know is how many patients can remain on the same treatment for more than 6 months. That is endocrine with CDK4/6. And they were able to show that in 47% patients. So it is a good strategy. It's not
Yes.
for everybody, but I think a 3-year PFS showed it.
Yes.
So this, I think we've discussed. Maintain was the only positive study, if you call 5.3 versus 2.8 months positive. And then,
Ma'am,
of
if
course,
you
you
had
have the
another option,
post-monarch in patients who receive.
ma'am, if I may come in, if you had another option for instead of the CDK4/6 inhibitor and fulvestrant, would you have not addressed the liver lesion and just changed the systemic therapy? As in not treated it as an
So my reason
oligoprogression.
for... So you're saying when she developed one MET, right? When she
Yes.
developed a single liver lesion.
Yes. We caught, I mean, we probably caught it
the medical
because
oncologist, you will do regular scans if the patient, she was metastatic to start with, right? So you would do 6 to 12 monthly scans in this patient, and then you do it, and then it picks up the single liver lesion. But somehow we feel that she's done so well for 3 years. The patients progress after 12 months, 24 months. There's data to show that the longer they are on fulvestrant CDK4/6, the better biology the better other treatments will work later as well. So when you have a single lesion and I'm addressing that, I would definitely want to take out more benefit from the same treatment and continue it for some time. And even if I get 6 to 12 months more, very happy with the result. It's a chemo-free time. He's feeling well. It's well tolerated. And like Anved said, the options are pathetic after that. You try putting patients on alpelisib, it's a nightmare for these patients. Everolimus is not easy to give. And then they have a PFS of 6 months after that, max, maybe 4 months. And then you're back to square one. And then you give chemo, and then how long do you give chemo for? You can't go on endlessly. So
yeah, and the data for rechallenging the CDK4/6 also following progression is not great. So even if you change from, say, one CDK4/6 to another, it doesn't actually serve the purpose.
Absolutely. Absolutely. And, most probably we switch from palbo to ribo, but now because of OS benefits, we are starting ribo up front.
Yes.
Or abema up front.
Or
Then
abema.
what do you change to? Yeah. So I think that brings us to the end of the discussion. I'm not going to trouble you all with a rapid fire round at this time. So thank you for your attention. Nita, any comments or any conclusion?
Yeah, so just to say thank you. We've had a really interesting session. I've sent Shona some comments that I've got from a bunch of people. Half the world is in love with her, even more now. Excellent
Oh my
session, Shona. Thank
God.
you so much.
Thank